Alrighty, so in this study, I wanted to go over um, scoring and respiratory events and your titration. So this was a split night, so we're just going to start with the diagnostic portion here. I already went through and restaged some of this, and so some of the events that you marked might or might not stay based on whether I took out or added an arousal. Um, but here we go, right into the sleep. And throughout the study, just make sure that um, you're increasing these can flow and T flow lines or decreasing them so that you can see them properly. You kind of want the peak to be touching this line as you scroll over, and then the bottom uh, touching the bottom, so you have a baseline. Okay. So far, so good. Looks like a little bit of an oxygen issue, but since it's a split, you didn't do anything about that right off the bat, which is good. And from the hypnogram, it kind of looked like this patient in particular had some REM-related apnea. Okay. Okay, so looks like you missed a few hypopneas here. You can see there's definitely a decrease going on right in here, starting right here at this wave to this wave. And then same here from there to there. And then this one could even be, see how this is like a slanted, it's what I call a flat top, where this one here is nice and round, and then this one here kind of starts a little bit of a slant. Definitely by this one you have that slanted top. That's where I would start this one and bring it all the way to here. So I'd add 3 hypopneas to this. We have a chunk of weight. And it looks like the can flow is kind of not working properly. Might have fallen out a little bit. I'm just going to delete the T6 here. But it looks like you accurately placed these hypopneas anyways. We'll see how long this can flow lasts. Okay, and then like I said, this is baseline breathing in the T flow right here. So I'm going to just increase that a little bit because it is not within, um, there we go. So that's kind of the view you want to be looking at as you go along. Um, and that would change this event here to an obstructive apnea because you have flat tops, maybe one tiny blip, 2 tiny blips in here, but for the most part it's just a flat line. So I would change that. Um, this one, I think I would take it to about here. Once you see in the can flow, you can see the increase right there a little bit. And then this one I would also mark here with that arousal. Doesn't have a DSAP, but you don't need it. You need a DSAP or an arousal with hypopneas. So obstructive apneas, you don't need a DSAT, you don't need an arousal. You can just mark them when you see them. Let me scroll back a little bit to this event here. And it's really hard to say where this one starts or stops because the can flow is kind of out. But I think you're right. I think it does start here and ends here. So you had it right. And I just don't think the can flow, like, look, if I increase this to where I can actually see a baseline where I want to, there's no real way of telling what's actually going on here, so I don't think this is markable because it kind of just looks like the rest of this garbage that you're seeing in the can flow. So this is something that should have been fixed by now because you just can't see, you can't mark hypopneas when it looks like this. You can't see anything. So you can't mark this because there's no real decrease in flow in the T flow if you're going to judge based on the T flow, because you really can't judge whether it's an event based on the can flow because it's out. And then same here with this one, it looks like that could maybe be an event right there, but you just can't mark it because the can flow is out. And then same sort of thing with this. I can't really mark anything going on right there because the can flow isn't showing, and nothing is really happening in the T flow for it to show a hypopnea. And same sort of deal here. You can't really mark this hypopnea because there's no decrease in flow really in the can flow. It's there might be, but it's just hard to say based on what we can see. So that something that to keep in mind is to kind of fix things like this, especially can flow, T flow. It's how you mark your events. So here I actually think maybe there's enough showing, maybe there's enough showing in the T flow and the belts for us to mark, and even in the can flow for us to mark a hypopnea here. That's kind of a guess, but you can see this airflow, this airflow, this airflow, and then it drops out, and then you can see this airflow, this airflow, this airflow. Yeah, it's really hard to tell what's going on. And then you can see in the effort belts and in the T flow that there is reduced breathing here, and you didn't mark the first one or the second one because of wake and stage 1. And then you went ahead and marked the third one, so good job there. I'm thinking you can mark this one as well because you have an arousal. That might have been an arousal that I added when I rescored or restaged the study. And I don't think you can mark anything here as far as how long that is because you still have if there's anything, it's maybe from there to there because you have regular airflow all throughout the T flow. Nothing really changes except for towards the end, like right here. So maybe there's a hypopnea there, but it's just so hard to tell. And then same here. I think you're probably right, but it's just one of those things again that you should really just go in and fix the can flow so you're not guessing on all these events. And then same sort of deal here. Not really any change in the belts, so I don't know if I would mark that one or this one or this one. I think you're just guessing here. This is more of an educated guess because you can kind of see a little bit of action happening here in the can flow and then happening here in the can flow. And then so that signifies that there's potentially a decrease right here, but the belts don't show it and the T-flow doesn't really show it either. And then same here. This shows the can flow is showing that it's all kind of normal. The belts don't change at all. I would have to increase these to the point where it's unreadable to see if there's an actual decrease going on there. And you just can't really see what's happening. Same here. If there's anything, maybe it's right here actually, but I don't think that I'm confident enough to mark that. And it could be something going on here too, but just not confident enough without more showing in the can flow. And then with these here, I'm kind of seeing the same sort of deal. You have the decrease, and you have maybe a slight decrease in the thoracic belt, but nothing really changing in the T flow, significant enough. Nothing really changing. Like this all looks very normal breathing. I just need that. I just need that can flow put back in properly to really see if there's flat tops or if there's something else going on that I'm not seeing. But we don't have that right now, so we'll just leave those unmarked. And this is a little bit easier to see. You have some airflow going on here and then it slowly dips out. So I think you can mark that as a hypopnea. I don't think I would mark the whole thing from there to there. Just when you have that can flow go out all the way. And then same with this one here. I wouldn't mark that whole thing. I'd just mark where the can flow drops out. Because that's what you can barely see. And then with this one, I don't think we could mark this one technically. Actually, with the reduced breaths and the T flow, maybe we could mark it from there to there. It's just tricky, so you can't really see what's happening. And then in these, you definitely have, at least we have the T flow because went out completely for an obstructive apnea. So I think you're right marking that. And then the can flow's kind of coming back in a little bit enough to read. So I think you're right with the hypopnea there. I think you're right with the obstructive. This hypopnea, I would mark this one as well. And this one, I'll just move over just a little bit. And obstructive, good. And another obstructive, good. And then this, I don't really see any, I mean, you can actually see this whole bit is reduced in the belts and the T flow. So maybe that whole thing is an event right there. And then that one, the T flow is it's kind of being finicky, but it looks like it's back in a little bit better. You can see the reduction in the flow, but it drops to a flat line almost. And then the obstructive apnea there that crosses through. I would struggle to mark this whole thing as an obstructive because you've got this arousal here. I think the obstruction is probably right here, where you have the flat line, because the flat line in the T flow, because you still have some breaths going on right here. Not very legible, but I could also go in and check this arousal, but I'm not going to bother. I think the staging was good. And then another obstructive here. Big old DSATs going along with these two, from 93 down to 83. And then this one, I would actually mark obstructive because you have that flat line going all the way from there to there. So rather than marking the hypopnea as a whole, you mark the obstructive. If there's an obstructive in there, you mark the obstructive, like you did with this one. You didn't score this whole thing as a hypopnea. You just marked this bit as obstructive. So same scenario here. You don't mark this whole thing as a hypopnea. You just mark where there's the obstruction. Now, if flow continued and you still had the DSAT, if it wasn't an obstructive apnea, then you'd certainly mark the whole thing, but that's not the case. And then in this one, I think the recovery breath happens right here. And then you went in for CPAP. Then we have a chunk awake. Let's just skip over to the sleep here. Okay, and I don't see anything happening here. I'm not really sure what you're marking again. Let me increase this a bit. And we'll see everything is kind of right around the same. Like the peaks and the troughs, they're almost all touching the in between my marker here, the gray marker. Goes up to the top, then down to the bottom, up to the top, down to the bottom, up to the top, down to the bottom. There's no decrease in flow, which is why I've deleted that event. So you're making up hypopneas, and that's kind of a common theme I've seen over the past 3 studies, or past few studies anyways, that you kind of mark hypopneas with arousals or DSATs even when there's no reduction in flow. And you have to have that reduction in flow, at least a 30% reduction in flow, to mark a hypopnea. There's just nothing there at all. It looks like actually I need to increase my belt here. And then same here, you can kind of see in our line here, nothing really is decreased flow here. You might have increased respiratory effort or increased respiratory right here, but that doesn't mean that there was a decreased that doesn't mean there's decreased respiratory flow or effort. Just because there's a little increase right here doesn't mean it's a hypopnea. So what do we have here? This kind of looks the same. And you can even see in your within your hypopnea, um, like your hypopnea, the width of the pink section is the same width as the gray section, right? So when you mark your hypopneas, if all of your lines, if all of your flow lines are, I mean, if I were to put this hypopnea here, it looks the exact same. It's almost touching the top on all of these. And if I put it here, it's still the waveforms or the inhalation. It's almost touching the top on all of these. So it just seems, um, yeah, I just don't know why you're marking these as hypopneas. Maybe just because there's an arousal, or maybe because there's a weird breath happening right here. But what you need to worry about is the reduction in airflow by 30%. And there's no reduction here at all. And same here, there's almost an increase in respiratory right here. You have one that doesn't quite touch the line, and then you have increase, increase. So I'm not sure why this one was marked. It's the opposite of what's supposed to be happening almost, because you have lines that are even touching the top of the pink block, so to speak. We'll take that out. If there is anything, um, see how in here this one kind of is a little bit, tiny bit lower than baseline. It's not quite getting almost to the top. It's just, um, but that's not a 30% reduction. And then by this breath, it's back to normal, which is too far away from that arousal to mark a hypopnea. And it would be not enough reduction in airflow to mark a hypopnea in the first place. Okay, and then for this, I'm going to delete this. And you can see that the same sort of thing is happening. You have a reduction here and here, and then this is normal. It almost touches the top line there. So you're not really having a reduction. I think what you're seeing is this like weird recovery breath right here when they wake up, which is kind of normal when you have an arousal, to have a weird breath or a couple weird breaths. But that doesn't mean that there's a reduction in flow. You kind of have an increase in flow right here for this breath. That's going to be definitely touching the baseline, the upper section of the baseline airflow. But then it kind of normalizes again. And REM is like this a lot. You see maybe faster breaths or slower breaths. Um, I don't think that's a hypopnea. Get the old loading bar. Okay, so same here. This is all baseline, and then maybe a slight reduction, not quite 30%. It's almost the same as these here. Um, but I think what you're seeing is you have an increase and an increase on either side. So you're looking in between these two and going, well, this must be an event because it looks reduced from this point and this point. And you wouldn't be wrong if that's what you're thinking, but it's reduced to the point of baseline breathing compared to what we're seeing in REM. So I don't think this is a hypopnea. And then same deal for this one here. This is all kind of baseline breathing. But you increase to 7 for RDI greater than 5 and snoring. I didn't see the snoring, but I don't have it boosted up at all. So, see, there is some snoring, a little tiny bit. Okay. And then see how this is increased respiration? This is not decrease, this is an increase. So this is the opposite of what you're looking for, and this is not a hypopnea. You want to see reduced breaths, not increased respiration. And then same here, see how all of these kind of touch baseline? That's going to be not a hypopnea there. And then same here, this is kind of an increase. Oh, where did I go? This is kind of an increase again in airflow and respiration. So that's not a hypopnea. What would have been is if there was a DSAT to match this event here, because that's definitely a reduction. You don't even have, like, this is nowhere near this line. All of these little breaths they're not anywhere near baseline breathing, right? But there's no DSAT here, and there's also leak, so um, that's one thing to keep an eye out for is if they have mask leak a little bit. It goes from about 28 to 39, 41 here. So I'll delete that. So far, no events on 7 centimeters. Might be a little bit more snore, tiny bit of snore going on still. And you start at O2. 1, 2, 3. Okay, so that's good start of O2. And this central is after this arousal, kind of after a deep breath as well. I wouldn't mark this as central apnea. Back to REM. And this is REM supine, which actually looks fairly good for 7 centimeters. And then, again, I might have to increase my, there we go. my pat flow there and increase my, so you're constantly messing around with these things, and especially in REM. So you can kind of see a baseline for your breathing, and you can see as I drag across here that it's either touching or nearly touching the top of that baseline, and then decreasing down to the bottom baseline there, and nothing is happening here. This is doing the same thing. It's almost touching and touching, almost touching, touching, almost touching, touching. There's no decreased respiration or decreased airflow in there. So again, I have to decrease a bunch of stuff that we're looking at so that I can see what's happening. Looks like this is now well over the baseline in my gray lines there. There we go. That's just almost touching. So I have to increase and decrease these things throughout the night quite regularly. And then you turned the flex off here. Oh, it could be a smart move. Okay, we got another hypopnea here. Let's take a look at that. And this is happening after a big deep breath, and then you have another big deep breath for the arousal. But in between, there's no reduction in airflow. So again, with this, they're almost touching the baseline. And so here again, they're slightly reduced, but not 30%. It's just ever so slightly. And I think, when someone takes a big old deep breath, they're not going to need as deep of breaths um, for the next few breaths. So I don't think there's any reduction in flow here. So I'll delete that hypopnea. And then again here, just not sure what you're seeing in these. I'm going to delete that. Maybe you're seeing the increased flow and thinking that something must have caused that, but yeah, the arousal probably caused that. You know what I'm saying? And then same here. This is all almost touching, almost touching, almost touching, almost touching. And compared to baseline, you have the same thing happening everywhere else. So I wouldn't mark this one. Where did you jump to 8? I did not see that. They looked fine on 7, technically, after taking out some of these events. Oh, for snoring. Okay, that's fine. Yeah, a little bit of snore going on. That makes sense. And now we're getting more central apneas in here. But this is right after wake and right after 4 really big deep breaths. So I don't think that's actually a central apnea. I just think that's him trying to fall back asleep. So I wouldn't mark that one. And same, nothing in here. And then here you marked an event, which I think you might be right. However, yeah, this event is kind of from there to there. And the problem with this event is it's happening right with the leak that's, excuse me, happening right here. So I would actually delete that and make a comment saying leak. That way you don't want to increase for something like this because it was happening during leak. And then same here, this would normally be an event. You have quite a reduction in flow here compared to here. So you have all these events that are touching baseline and then going into here, no longer touching and quite below baseline. But again, with this, you have leak, so I would just not mark that and just put in a comment that says leak. And then you have lights on. So I think this, overall, looking at this, you have a good titration. I don't actually think they had any events on PAP once you put them on. You marked a few events and increased for RDI as well as snore. I think you probably could have just increased for snore on these, just ever so slightly. They had some snore, but overall, I deleted quite a few events in the titration portion, so just be aware, and hopefully that trick helps you. Measuring baseline, you can use the pink box that you have when you mark hypopneas. It should be significantly less flow in the box, and a lot of times the when it drops to baseline, if it drops and it doesn't hit baseline, that's going to be also a reduced breath too, because a lot of times apneas will happen on the decrease or on the exhalation. Someone will exhale and they'll stop breathing right there, you know. So look at that lower baseline as well as the upper baseline, and hopefully that'll help you out. But overall, good titration. I think you got them fixed, and they're going to be a lot happier on CPAP. So I'm going to make another video for you for your second study, and that way you have 2 videos to go over tonight. All right, this one's a short one, and I hope it helped.